Hi, my name's Maddie McCauley, and I did my project on alternative treatment for chronic low back pain. The clinical topic background: chronic pain is pain that lasts for over 3 months, according to the Cleveland Clinic. This pain can often have a root cause that may go undiagnosed or may be untreatable. Due to this, often opioids or other pharmacological interventions are prescribed. This can increase the risk of substance use disorder, accidental overdose, inappropriate disposal of unused opioids, and inappropriate prescription of opioids, according to the Office of Disease Prevention and Health Promotion. According to Healthy People 2030, about 1 in 12 adults in the U.S. have high-impact chronic pain. Chronic pain also can increase risk of anxiety, depression, suicidality, Alzheimer's disease, and dementia. So obviously this affects quite a large portion of our population in the U.S. So further, I went with my PICO question, and in adults with chronic pain, what is the effect of the use of chiropractic care, acupuncture, and massage therapy, so essentially alternative therapies, on improving quality of life and decreasing pain levels compared to those who are prescribed opioids or pharmacologic intervention? I found a study completed by Morillon, Bengalti, Degenais, and Poder, and they conducted this study, and it was published in 2023 to address chronic low back pain and non-surgical alternative treatments. They conducted a discrete choice experiment in Quebec, Canada, with 424 adults who participated with chronic low back pain, which is, according to them, defined as back pain lasting for greater than 3 months. The purpose of this study was to assess patients' preference for non-surgical treatments for chronic low back pain. The researchers utilized an online survey to determine patient preference for treatment. The survey included questions of treatment modality, pain reduction, onset of treatment efficacy, duration effectiveness, difficulties with daily activities, sleep problems, and knowledge of his or her body pain and location. The treatment modalities that they included were corticosteroid injections, supervised body-mind physical activities, so yoga, tai chi, pilates, supervised sports and physical activities, active walking, swimming, bike riding, weight training, and CrossFit. Physical manipulation, so chiropractic care, physiotherapy, occupational therapy, self-management courses, so medication, self-hypnosis, breathing techniques, relaxation, and psychotherapy, so cognitive behavioral therapy, post-traumatic shock, progressive muscular relaxation, or a motivational approach. As far as pain reduction, they wanted to know if it was none to very slight, reduced by half, or no pain. And then as far as knowledge of his or her body pain and location, they wanted to know, do they have the same knowledge as before, knowledge is somewhat better than before, or knowledge is much better than before. The responses were analyzed using hierarchical Bayesian analysis and latent class analysis. The experiment findings showed that patients found treatment modality to be most important. The patients were split up into 6 different classes by the latent class analysis that was used, and the following results were ranked by importance as follows. So they, after treatment modality, they found pain reduction, then difficulties with daily activities, then duration effectiveness, then sleep problems, improvement of sleep problems, onset of treatment efficacy, and knowledge of the patient's body and pain location to be most important in that order. The majority of patients preferred physical manipulations, self-management courses, and supervised exercise programs over the corticosteroid injections. Many actually refused them, and then also over the psychotherapy. The clinical recommendations by this article were to include the importance of discussing patient treatment preference and consideration of patient preference by the provider when formulating a treatment plan. The evidence proved that through the variety of responses, there's really no size-fits-all treatment when it comes to managing patient care and chronic pain, and that patients should be highly involved in the decision-making process of their care. They see better outcomes with pain management doing that. My project purpose is really just to highlight those things. So just really highlighting the importance of utilizing patient knowledge and input on how their personal experience of living with chronic pain affects their care. and their outcomes. So just recognizing that, especially with such a large population experiencing chronic pain, and then also not only the pain that they're living in with their body, but also the increased risk for anxiety, depression, suicidality, and then memory issues as well, that it's just so imperative that we as healthcare providers just engage with patients to see like what has worked for you, what has not worked for you in the hospital. If you're in a hospital setting with patients, rather than always recommending one type of pain management, maybe engaging and saying, hey, like, have pharmacological measures worked for you, or do you have better success with alternative treatments? And then seeing if we can either do referrals or what have you, just to encourage that patients are really a little bit more engaged when it comes to their pain management, especially for those with chronic pain. As far as implementation strategies go, I would include educational outreach, so just encouraging the providers to engage with patients on treatment preference, and then also education on patient preference for treatment and just how important it is and how it affects their outcomes. I would utilize email reminders just as a touch point for providers to engage, but also as a newsletter for patient outcomes and new evidence-based practice research. I would also utilize computer prompts, preferably in the form of an EHR questionnaire for providers to engage with, or the nursing staff to engage with the patient, asking them, what treatment modalities they prefer, what symptoms are they experiencing any sort of relief from their symptoms with the treatment modalities that they prefer, things of that nature. And then I would also utilize computer prompts for education. So whether that be in the after visit summary or just in their chart to be able to add in education for them. And then I would also use feedback. So doing chart audits to ensure that the questionnaires are in fact being utilized. And then also, is there adequate documentation so that if another provider sees this patient in another setting, or perhaps another provider within the same setting sees them, that they have a decent amount of documentation to be able to just refer back to, so that way the patients aren't consistently having to advocate for themselves in the ways of how they would like their pain to be managed. The strategies to evaluate the outcomes, I would measure how frequently charting is actually happening. So at the start, prior to utilizing some of the prompts or the education or different things, performing chart audits on select group of patients, seeing how frequently charting is happening, and then documenting that, moving forward 3 to 6 months, doing the same thing. Hopefully they are being utilized, and if not, just continuing to educate providers and nursing staff. And then going out a year further, setting an expectation for percentage, hoping that percentage is not only being maintained, but even being improved upon. And then utilizing a measurement for patient satisfaction for pain management options, utilizing that same time frame. So at the beginning, 3 to 6 months out, and then a year out, and then also just setting a standard for percentage, and not only should it be maintained, but it should be improved upon. My references are listed below. Thank you so much for listening to my presentation.